Talked about the blue bloaters. Now we're moving on to the emphysema patient who is the pink puffer. And the pink puffer is the person who has emphysema. And you remember that in emphysema, it results from the destruction of those airways that are distal to the terminal bronchioles. And so not only is there less surface area for gas exchange, there's also less vascular bed for gas exchange. So the body then has to compensate by hyperventilating. And so this hyperventilation is where we get the puffer part of their name. And because this patient tends to do such a good job in the beginning of this hyperventilating or compensating, their blood gases actually stay relatively normal until they're fairly late in the disease process. Eventually, because they have a very low cardiac output, these people with this disease begin to develop muscle wasting. And so as you look here at this little Pink Panther depiction, you see he has the big barrel chest that we'll talk about in a minute. You see that he has the pursed lips that we'll talk about. And you see that he has real skinny little arms and legs compared to his big barrel chest. And that is from the muscle wasting. They actually have less hypoxia or hypoxemia as compared to the blue bloaters, and they have a pinker complexion and get that pink puffer name, partly just due to the work of breathing for them. So if you picture this person who has such a limited air exchange and they are trying to compensate by doing a number of things. They tend to get in a tripod position. So if you look at him there, he's got his arms rested forward. Often they'll put their elbows forward onto a table and they'll lean forward so that they are trying to get full expansion of the chest, let the chest drop forward so there's no extra weight on them. And then they'll purse their lips because their expiration tends to be longer than their inspiration as they try to get rid of that extra CO2. They purse their lips to try to assist with that. And also they have that big barrel chest, so the anterior-posterior diameter of their chest, rather than being 1 to 2, tends to be 1 to 1. And so this person, as you begin to assess them, you'll see there is CO2 retention. They don't have the cyanosis typically. They do have pursed-lipped breathing. They have dyspnea. They have a very ineffective cough when they do cough. They have hyperresonance of the chest when you percuss them. So as you're doing chest percussion on a normal person, you will get resonance. Because you're over an air-filled pocket. On this person, because of the hyper extension of the chest and because of that barrel chest that you have an even more noticeable resonance there. It's a hyper resonant sound, like you're banging on a hollow drum. They are orthopnic. They cannot lie down and sleep at night. They tend not to rest well. They have exertional dyspnea, and as the disease progresses, they have dyspnea at rest. They have that prolonged expiratory time. They speak in short, jerky sentences because they can't complete a sentence due to shortness of breath. They have to keep getting a breath. They tend to have high levels of anxiety and use their accessory muscles to breathe. So you'll see their neck veins sticking out and the tendons in their neck stick out, and they'll raise their shoulders and lower their shoulders to help them to get in a full breath. Again, thin in appearance other than the barrel chest, and they tend to also develop that right-sided heart failure. This carries out the comparison of chronic bronchitis and emphysema a little further. One thing that you'll notice is the diagnosis of the two disorders. So for chronic bronchitis, it's a clinical diagnosis that's based on their symptomatology. So they need to have a daily productive cough for 3 months or more out of the year for at least 2 consecutive years. Can't be 1 year, can't be 1 year and skip the next and then again the following year. It needs to be at least 3 months and at least 2 consecutive years. Typically, your patient here is going to be overweight. Often they're cyanotic. We talked about that. Generally, they're not going to present for the very first time as cyanotic as this patient here, but late in the disease, they will present very blue, very blue. They do have elevated hemoglobin levels. They do have the peripheral edema, especially once they start to develop the heart failure. And what you will hear with this patient as you auscultate the lung sounds is rhonchi and wheezing. So why are we going to hear that if we think that through? As you think about the bronchitis patient and you think about all of those secretions up in the bronchus, think bronchi, rhonchi. So those secretions are what's causing the rhonchi noise. And as you think about wheezing, think about the fact that the diameter of that bronchus has been squeezed in because of the edema, because of the inflammation, or because of the secretions, all of the things that are going on in there, and the constriction of the airway. You have a smaller pipe, and as air goes through a smaller pipe, you know that you get that whistling sound or the wheezing sound. If you don't know what rhonchi and wheezing sound like, then this is the time to get online and listen to that, or go back to the lab and listen to that on the SimMan. Then as we move to emphysema, we see that this is a diagnosis that is diagnosed by the pathology. So there's permanent enlargement and permanent destruction of the air spaces distal to the terminal bronchioles. So what do we mean by that? We mean that their alveoli are permanently damaged. They are enlarged in some places. They are destroyed in some places. You have the septum walls that have been broken down. This patient tends to be older and thinner. They tend to be severely dyspneic. They tend to have a very quiet chest as compared to the patient with bronchitis. So rather than hearing adventitious lung sounds with them, you're not going to hear lung sounds, or you're going to hear very diminished lung sounds. And so this person would come in and have a chest x-ray, and on their chest x-ray we would see hyperinflation of the chest wall, of the lungs, and a larger chest wall, and then we would see that the diaphragm, actually that bottom part of the diaphragm, has been flattened out. It doesn't have the usual curve that a patient's diaphragm would have. So one more comparison here, we have the patient with chronic bronchitis at the top. On the left you see the healthy bronchus, and you see how it is open, nice and wide. There's no inflammation of the bronchus. There's a nice wide pipe, and in addition to that, there's no mucus running through it. As you move to the right, you see the person who has bronchitis or is in an exacerbation of their bronchitis. And you see the inflammation there, and you see the excessive amounts of mucus. Underneath that, you see the patient with emphysema. To the left, you'll see the healthy alveolar sac. To the right, you see the alveolar membranes are breaking down. You see that the walls are starting to break apart. And so this patient has a diminished capacity for gas exchange. As you look at that in the patient's lungs, follow the line. You follow the chronic bronchitis lines, and you see that it's up in the bronchus or the bronchioles here. And so here it's following down into the left bronchial airway. And then as you follow the green lines for the emphysema patient, you see that it's clear out in the distal airway, out where the alveoli lie. And so that's the big difference in those disease processes. Well, you should have a pretty good idea now what the two types of COPD are between bronchitis and emphysema. This slide shows you between the two types of COPD and asthma. And we're not going to study asthma particularly in this class, but it is a comorbidity, and a lot of the treatments are the same, and so you should just know a patient with asthma has triggers that they have to avoid. The patient with COPD doesn't necessarily have the same triggers, but they do have risk factors, And those who have the comorbidity of asthma also need to avoid those risk factors because they can set them into a severe COPD exacerbation. So when you're thinking asthma, you're thinking more of the large airway. When you're thinking COPD, you tend to be thinking of the bronchioles and the bronchus and the alveoli. Looking at the etiology of COPD, it is a leading cause of death, illness, and disability. And as we think about the disability portion of this, it is a hot topic right now in the United States because employers are starting to look at the cost of having employees who are smokers because they tend to miss more time from work, because they tend to have higher healthcare costs. And the disability insurance and the healthcare insurance tends to go up for all of the employees due to the illness of these employees. About 80% of people who develop COPD are patients, are people who smoke. And because of that, the disease is looked at as a preventable disease. The rest of them are generally due to environmental exposures, and also can be partly due to secondhand smoke. But the costs have raised questions that we'll talk about later as we get into ethics as well. But they've raised costs to the point that employers sometimes will not hire people now who smoke. Risk factors for COPD then are the biggest one, smoking, and second biggest are short-term exposures to high levels of irritating substances or long-term exposures to smaller levels.